In this video, we're going to look at what ketamine actually does to the brain and why the phrase rewires the brain is both useful and misleading. Ketamine is often described in extremes. For some people, it's presented as a breakthrough treatment for treatment-resistant depression. For others, it's dismissed as a dissociative drug with a placebo problem. The clinically useful question is this: what state does ketamine create in the brain, and what has to happen during that state for change to last? I'm Dr. Sanil Rege, consultant psychiatrist and educator. And in this video, I want to take you beyond the usual simplified story of ketamine blocks NMDA receptors and depression lives. By the way, I've now opened up channel membership. Members get early access to selected videos and priority comments, which helps me respond more directly and build a community around better neuroscience and mental health communication. Before we go into the mechanism of ketamine, a brief disclaimer. This video is for educational purposes only. It is not personalized medical advice. So let's start off with the important framework I want you to hold in mind. Firstly, depression is not just a low mood state. Depression is a condition that changes three domains: activity, cognition, and emotional hedonics. So when we ask the question, how does ketamine work? The better question is, how does ketamine change activity, cognition, and emotional hedonics? And after changing these three key functions, how does it create the conditions for new learning? That gives us three steps. First, destabilize the old pattern. 2, open up a plasticity window. And third, consolidate new learning through behavior, environment, and psychotherapy. That third step is one of the most crucial steps, which is often missed. And that third step may be the difference between a transient response, rapid response, and sustained recovery. So let's now touch on the mechanism of action of ketamine. We know that most conventional antidepressants work on monoamine systems: serotonin, noradrenaline, dopamine, and downstream effects unfold over weeks. Ketamine's different. Ketamine was originally used as an anesthetic and an analgesic. For more than 50 years, ketamine has been used medically as an anesthetic agent with potent pain-relieving properties. At anesthetic doses, ketamine can produce dissociative anesthesia. That means that sensory inputs may still reach the cortical receiving areas, but they're not integrated in the usual way across the association networks. Let me explain this simply. The brain receives signals, but the person's ordinary experience of self, body, and the environment become altered. At lower sub-anesthetic doses used in depression research, ketamine does not work like a standard antidepressant, but its effects can occur rapidly, sometimes within hours. And that's why it's a rapid-acting antidepressant. But the interesting part is this: ketamine has a short half-life, around 1 to 2 hours. Yet, antidepressant effects can peak later. So the benefit cannot simply be explained by the drug being present in the blood. Ketamine not only provides a rapid antidepressant effect, it also appears to trigger downstream biological changes that may temporarily alter how brain networks communicate and adapt. This is why the metaphor of rewiring became popular. But more precisely, ketamine may create a temporary state of increased synaptic flexibility. Delving deeper into the neurotransmitter milieu, the classic explanation starts with the NMDA receptor. Ketamine is an NMDA receptor antagonist. NMDA receptors are part of the glutamatergic system and are deeply involved in learning, memory, long-term potentiation, pain sensitization, and synaptic plasticity. But here's where it becomes really interesting, because ketamine does not simply turn off glutamate. So what ketamine does is it blocks NMDA receptors on GABAergic inhibitory neurons. We know GABA is the inhibitory neurotransmitter. So GABAergic interneurons normally act as brakes. Ketamine reduces this inhibitory braking. So what can happen is that there is a surge of glutamate release in cortical regions such as the medial prefrontal cortex. That glutamate then stimulates another group of glutamatergic receptors known as AMPA receptors. And AMPA activation appears to be a key part of the rapid antidepressant effect. So the simplified sequence is this: NMDA blockade, resulting in reduced inhibition results in glutamate surge. AMPA activation then results in BDNF and mTOR signaling, which are responsible for synaptic growth and plasticity. This is where BDNF comes in. BDNF stands for brain-derived neurotrophic factor. It supports synaptic growth, neuronal survival, and adaptive plasticity, sort of fertilizer for the brain's neurons. The mTOR pathway is another interesting pathway involved in protein synthesis and synaptic remodeling. So what ketamine may be doing is it's shifting the brain from a rigid depressive network state into a more plastic state, one that is more malleable to change. Now, why is this network change really important? Because we know that network level dysfunction forms a core part in depressive disorders. A default mode network may be excessively involved in rumination. Executive control network dysfunction results in inattention, difficulty with cognition, reduced cognitive flexibility. Executive control networks may struggle to regulate attention, planning, sequencing, and cognitive flexibility. The salience network may over-detect internal threat or distress. Ketamine may temporarily alter this network balance. And this is why some patients may describe a sudden change, a reduction in the emotional heightening of depressive thoughts, a brief separation from the usual narrative, the usual way of thinking, a sense that things can change. But this is also where we have to be cautious, because a plastic brain state is not necessarily or automatically a healthy brain state. Plasticity simply means the system is more changeable. What happens next matters. Now, before we go into what happens with the window, evidence also suggests that ketamine acts on opioidergic pathways and dopaminergic and noradrenergic pathways. So ketamine may have traditional antidepressant effects in addition to the rapid-acting antidepressant effects that I mentioned earlier. So now let's look at the key clinical point of what happens when the window is opened. So ketamine opens a window for neuroplasticity, but the window needs content, it needs direction, it needs consolidation. The patient may look outside the window, but may not know which path to take. If the patient returns to the same environment, the same sleep disruption, same avoidance, same interpersonal threat, same cognitive loops, and the same lack of behavioral activation, the brain may simply fall back into the old state. The brain's an organ of prediction, and shaping predictions forms a core part of treatment, because the brain is an expert at all predictions. Therefore, it's easier for the brain to fall back into its old predictions. This is why the phrase rewires the brain can mislead people. Ketamine cannot neatly install a new personality or a new way of thinking. It does not automatically resolve trauma. It does not remove the need for sleep or structure, social connection or behavioral change, or change in predictions. Here's a better metaphor. Ketamine may soften the rigid state the brain has been in, but what's placed into that softened and changeable state matters. A new routine, a behavioral activation plan, trauma-focused work when appropriate, a treatment plan that addresses sleep, substance use, inflammation, pain, and comorbidity. This is why ketamine-assisted approaches often raise the question of psychotherapy. Not because psychotherapy is a vague add-on, but because neuroplasticity without consolidation is a missed opportunity, or can be one. The brain may be more ready to learn, but it still needs to know what to learn. And this is where psychotherapy becomes important. Because the crucial aspect in treating depression is not about mood. In fact, I've covered this misunderstanding about narrowing or reducing depression down to mood in this video here. What we're really trying to do is to change the brain's prediction. The prediction that nothing will improve. The prediction that effort will not matter. The prediction that the future is closed. And often these predictions are so deep that they're outside conscious awareness. What ketamine's done is it's brought these predictions up to the conscious awareness so that change can now happen. Let's touch on a recent study that highlighted the importance of this window. A recent randomized trial compared repeated ketamine infusions with midazolam in hospitalized patients with depression. Midazolam was used as an active comparator because it has psychoactive effects, which helps with blinding. What this study showed is that ketamine did not significantly outperform midazolam, a benzodiazepine, on the primary depression outcome at the end of treatment. Surprising, isn't it? There were also no significant differences on secondary outcomes such as self-rated symptoms, cognition, quality of life, or economic outcomes. Both groups, ketamine and midazolam. So does that mean that ketamine does not work? No. It means we have to understand the broader treatment context. Earlier studies and reviews suggested rapid antidepressant and anti-suicidal effects, particularly in treatment-resistant depression. But we know that the response can be short-lived and difficult to separate from expectancy, dissociation, and the broader treatment context. What this ketamine versus midazolam study teaches us is that the setting, expectancy, containment, monitoring, note these were hospitalized patients, so the therapeutic environment may be doing more than we realize. That of course does not mean that ketamine does not work. It simply means that ketamine is one part of a system, and addressing depression means we need to target multiple systems at different levels in the hierarchy. So clinicians should always consider ketamine, or any other treatment for that matter, within the treatment context. Which patient type is likely to have the best response? Which depressive subtype? Which comorbidities? What treatment setting? What psychological and behavioral strategies? And what are the risks that need to be monitored? Whilst we've spoken about ketamine, we also have the S enantiomer, which is esketamine. Let me explain. Ketamine used medically is often racemic ketamine, meaning it contains two mirror image forms, R-ketamine and S-ketamine. S-ketamine is the S enantiomer. It has higher affinity for the NMDA receptor than the R enantiomer and has been developed as an intranasal formulation for treatment-resistant depression. Intranasal esketamine is generally used under medical supervision, often alongside an oral antidepressant, with monitoring after administration because of side effects such as dissociation, sedation, blood pressure changes, and other safety concerns. From a mechanism perspective, esketamine also acts through the same pathways as ketamine: NMDA receptor modulation, glutamate release, AMPA, BDNF, mTOR. So what are the risks and clinical cautions? Ketamine is not a benign intervention. It can be associated with dissociation, perceptual disturbance, sedation, nausea, dizziness, blood pressure elevation, anxiety, and in some cases, psychosis or manic episode. There is misuse potential. Chronic recreational use has been associated with cognitive issues, urinary tract injury, and other harms. Repeated high-dose exposure raises concerns that are not fully answered by short-term clinical trials, and this is important to consider for clinicians using it from a longer-term perspective. We have to exercise greater caution in individuals with psychosis, unstable cardiovascular disease, uncontrolled hypertension, substance use disorder, or certain personality and dissociative vulnerabilities. So let me summarize all of this for you. So let's return to the original question. How does ketamine actually rewire the brain? It probably does not rewire the brain in the simplistic way social media suggests. It alters glutamate signaling, enhances monoamine transmission, modulates opioidergic systems, reduces inhibitory braking and key circuits, activates AMPA receptors, increases BDNF and mTOR-related plasticity pathways, and shifts network dynamics involved in activity, cognition, emotional headaches. It opens up a window. But what happens inside that window determines whether change becomes clinically meaningful. That's why ketamine is best used in conjunction with psychotherapy, behavioral activation, sleep restoration, social rhythm therapies, substance use treatment, and addressing comorbidities. So if there's one thing to take from this video, it's this. Ketamine may create the conditions for change, but does not replace the work of change. The brain may become more plastic, but plasticity needs direction. You're listening to the Dr. Rege channel, and I'm Dr. Sanil Rege. If this helped you think more clearly about ketamine, depression, and neuroplasticity, like the video, subscribe to our channel, and share it with someone who's trying to understand the science of ketamine. If you'd like to support the channel, membership gives you early access to videos, priority comments, badges, and emojis, while helping me keep creating grounded psychiatry content. For psychiatrists and mental health professionals, we explore these mechanisms in more depth inside the Academy by Psych Scene. I look forward to seeing you in the next video. Until then, stay curious. Bye-bye.